All right. Good morning, everyone. Welcome. My name is Michael Okali. I will be moderating this session. Um, as we all try to join, let's give some time for other colleagues to also join in. Welcome, everyone. Just a few minutes for others to join in. Please confirm if you heard me. Am I audible?
Yes, I
Very
had.
clear, Michael.
Beautiful. Thank you. So let's give other colleagues a little bit of time to join, then we'll kickstart. Thank you. So as we're waiting, you can also send a reminder to any of your colleagues that you know that have registered for the webinar. You can just send a prompt to remind them to also join in. It promises to be a very interesting one. Thank you. Okay. Yeah, I think we should start. To start with, I want to welcome you once again. My name is Michael Okali. I'm a senior health education officer with the Nigerian Center for Disease Control. And I'll be moderating this section of the Lassa Fever webinar series. This is the first, and there are also going to be subsequent series that will handle different thematic areas. Um, so for today, we'll be looking at the title Localizing Communication to Combat Lassa Fever. We're all aware that Lassa fever has actually been a fight in the country, and we keep responding and finding strategies and approaches that will suit what we intend to achieve. So we'll also be looking at the role of social-cultural context in effective community involvement or participation. So there we have very good experts and very experienced experts that will do justice to this. So, but before we continue, we need to lay down some rules that are going to make the whole section more productive. So, to start with, I want to assure you that NCDC and its partners, E-Africa and Breakthrough Action, are committed to providing an enabling environment for us for this webinar. So to make it more inclusive, respective, and also safe. So don't be afraid that anything or any hack can be done on this platform. It is very safe. So some of the ground rules, we just have 4 major ground rules. So I'll run through them quickly. All participants are expected actually to behave with integrity and respect. And seeing that this is a formal setting, we expect as much as that from all participants. So also for introduction, we have a whole lot of participants, so we'll not be able to introduce ourselves one by one. So please go to the chat box and introduce yourself in the chat box. And for affiliation, if you are a community member, please mention the community you are from. Yes, you're welcome to as an expert. If you have an organization you're affiliated to, you can write it in there. So for questions and answers, we have a Q&A box where you can put in your questions for every section. So there's a section for question and answer. We'll go to that and also address all your questions. So once again, kindly respect everybody's opinion and put in your questions in the questions and answers so that we'll address that. I'll quickly move to the objectives of this webinar. The first objective is actually we're going to be delving into crucial aspect of centering people for effective community involvement to build resilience for integrated disease prevention. So what we're going to look at here is to find out a way that will put community members, the people, the person at the center of all our disease integration and integrated disease prevention approaches. So talking about people, not other factors. So we're also going to explore tailored approaches that have been employed in Lassa fever disease prevention. We've done a lot. So we're going to look through a lot that we've done and see how the benefits and things that can actually be also improved on. So with this, the ground rules and the objective, we will go into the session proper. But before I continue, I want to see if we have Dr. Benga from the HCPR, Health Emergency and Preparedness and Response Department, NCDC, if it's online for him to introduce the chairperson for the meeting. Dr. Benga, are you online? Sorry, can anyone hear me?
Yes, Michael, we can. I don't see Dr. Benga online, so I believe we can just jump right in, and once he or the DG comes in, we would allow them to have the opening remarks. I hope you hear me.
Thank you. Thank you very much. Okay, so we'll skip this part of the agenda. When the DG, which is Dr. Jide Idris, the DG NCDC, it's online, then we'll give him this mic to introduce himself and also address the participants. So with this being said, we'll now go into the next item of the agenda. So can you scroll down a little bit? So we have three guest speakers. The first one is Dr. Denyi Hitler, the State Health Promotion Officer, Risk Communication Focal Person in Edo State Ministry of Health. We also have Mr. Sani Hassan, Infodemic Manager, Focal Person in Bauchi State. We also have Ms. Mewa, a Program Officer, Strategic Communication in Breakthrough Action, and we'll also have the pleasure to listen to Dr. Olainka, who's the DG Risk Communication Breakthrough Action. So we'll start with the first presenter. He's going to talk about the human-centered design and approach to understanding Lassa fever control in Edo State. Edo State has done a lot on Lassa fever, and Dr. Denyi will have the floor to actually share with us some of the experiences and some of the works that have been done. All right, Dr. Denyi Hitler, are you there with us?
Yes, I am.
Okay, you have the floor. Please go ahead.
Okay, can I have permission to share my slide, please?
I think that's been done for you.
Okay. Okay, I'm Dr. Denyi Hitler, as I've been introduced, so I'll move straight on. I will be talking on the human-centered design. Please, back to the beginning, please. Human-centered design approach to understanding Lassa fever prevention and control in Edo State. So next. So this is a qualitative research that was funded by the Breakthrough Action in collaboration with the NCDC and the State Ministry of Health. The background is that Lassa fever, as we all know, is an hemorrhagic fever, and then is endemic in Edo State. Intervention has been done, but majorly research has been focused on the clinical aspect of the disease and on the host. The other component, which is the human aspect, the human as regard the sociocultural environment have activities and the environment have not been studied. And that's why this research comes as a novel approach. The objective is to identify the current enablers and the challenges that spread Lassa fever with the focus of trying to develop effective preventive social behavioral change intervention to address them. Then the study location in Edo State is Esako West local government, which is a hotspot LGA. And then we focused on 2 wards, Uzare Southwest and Aushi 3. And then the study period is 2021 to 2022. So next. So the methodology, we employed a qualitative interview, then also direct observations and indirect observations. All these are to provide robust insight that we address communication intervention at the community level. Next. So in the interview course, we interview Lassa fever survivors, people most susceptible to Lassa fever, healthcare workers, farmers and food processors, community influencers and leaders, household influencers. These persons were interviewed, and then observations were made on the markets, the healthcare facility, the homes and public places. All these are community areas that people interact with in their day-to-day activities. Next. So thematic analysis was done to identify the key themes and findings, which will generate insight for knowledge and area for intervention. So next. So these are some of the themes, but for the sake of time, we are going to rush through some. We will pay attention to some, but when questions come, we attend to the question. So first theme that was identified was access and flow of information. There we find that there is insufficient dedicated scientific knowledge. And interestingly, this was found even among doctors. Because that's why one of the doctors said the first thing that comes to mind when we see a patient is high fever. And this is quite pathetic in an environment that is already endemic with the disease. So these is affecting, before you attend to malaria and you will realize later on that it's not malaria, a lot of things, infections have gone and the situation have worsened. Next. At the community level, there is also found a lack of general knowledge of Lassa fever. And this was found to be as a result of lack of information from the radio, from the TV, from printed material, and at the community discussion level. So because of no communication, what the people know about Lassa fever is majorly heard from words of mouth, and which is often inaccurate. And we also find that community leaders, chiefs, religious leaders also express eagerness to communicate about Lassa fever, but unfortunately, there have been no concerted efforts to train them so that they could provide lack of accurate information. That's why a doctor says we hear a lot about Lassa fever, a lot of radio sport about other disease issues, but there's less about Lassa fever. Next. So structural barrier that were identified, there were presence of holes in the wall, there were poor waste management practices, lack of built-in storage facility to protect food at the home, lack of safe spaces to dry and store food, lack of indoor kitchen protection, and then lack of water. So in fact, one of the participants that was met was even saying that he don't even know whether it is the rat poison that is the bait for the rat poison that he put that is even increasing the number of rats in his house, because there were so many holes that other ones outside are invited to come in. So these are all practices that were or barriers that were identified, and if any communication is to be done, we need to be addressed directly. Next. So unsafe eating habit was also identified, where the rat a meat. In fact, most of them consider the rat as part of the delicacy. They are highlighting that their forefathers have been eating the rat for long. And then there's open air drying of food that is being observed in the observation, and then the people directly report that they still eat rat, which is a big threat. Next. Then there's an issue of perception and practice. Why do people have a good perception that it's good to do house cleaning, use clean water, maintain a rat-free environment? They understand that from direct observation, there was a gap between perception and practice. For example, while observing a food vendor, one of the researchers noted this. He says, while she explained never leaving food remains uncovered, we could observe this not being the case. Then another observation says, she mentioned keeping our kitchen tidy and storing food safely, but we observe food in open and use dishes on the floor. So there is a gap between what people perceive as the right thing to do and outright practice. So a communication directed at the community level should identify that. And also, we also identify inappropriate use of chemical in or in the way of killing rat. These chemicals are brought too close to food sources, which could lead to poisoning. Next. Then there was also a breach of sanitary protocol that was observed at the health facility level. So health facility are supposed to they know the right thing to do, but it is when people like a team like us appear from direct observation that they try to put things in place. These habits are also risky in the prevention of Lassa fever. Next. Then fear of care seeking. This is very, very serious because the persons interviewed identified that health facilities are places of no return, specifically the Ira Specialist Teaching Hospital. Once a person has been tested positive and is referred, they don't want to go. When asked why they don't want to go, they see it as a place of no return, that most people that go there do not return. So instead of going, they use chemists and other TBAs, even as far as running, and this affects the disease intervention process. Many fear that if they go, they will not be able to meet their family needs. For example, a Lassa fever survivor said, I incur so many deaths for my son's Lassa fever treatment that I have not been able to pay for. Although presently, Edo State have resolved this in the last intervention by enrolling them in the health insurance scheme, which handle that fear. So, but the main one is the fear that if they go to ISTH, they will not return. So those are communication, these are gaps that need to be addressed through community involvement and communication. Next. Next. Hello, next. All right, then we have wrong and negative beliefs. This is, in fact, what one was not even expecting that a person at this stage will think that Lassa fever is a cause from witchcraft, punishment from God for bad behavior, that only dirty people get Lassa fever. People in rural area are less likely to get Lassa fever. That Lassa fever cases come from other states. In fact, some of the persons interviewed said that it is those travelers that are bringing the Lassa fever, that they do not have Lassa fever endemic in them. One wasn't expecting that, but that is the wrong belief that they share. Please, next. Then there's a vicious cycle of victimization. So because of lack of accurate information on Lassa fever, people tend to have negative view about the people that have Lassa fever. So people with suspected or confirmed diagnosis feel ashamed and afraid. So they keep it secret. Because previously, some have even said that it's as a result of his bad behavior, witchcraft, or his dirtiness. So because of that, they keep it secret. When instead of going out to seek treatment, they will be treating themselves in their house because of this stigmatization. So not talking about Lassa fever or sharing experiences create a taboo based on shame and fear of communication, in turn reinforces stigmatization and thereby even promoting the misconception further, because those that are survivors cannot openly communicate their experience with people. Next. Then there is a systematic denial. I will put emphasis on the distrust in the government, where community members are skeptical about any government activity. Of course, COVID-19 alluded to that. In fact, in one of our Lassa fever intervention, we were almost mobbed at the market square, all because we talk about Lassa fever. They said Lassa fever is not their problem, that government should bring them food. So they see Lassa, all those health activity intervention from government as government benefiting from them, not as them benefiting. Look at a farmer in the up corner. The farmer said, I heard people around me saying government members are not sincere when announcing case numbers. Use them to get support and aid. So anytime they see any government person, they know that they have collected money, and so this systematic denial also affects their belief in whatever intervention. Then stigmatization, which we have already mentioned, because they feel that it's a punishment for bad behavior. Next. Then here we now have using the sociological model, the findings have been synthesized into the various layers of the social ecological model. At the individual level, as we have said, we discover poor house maintenance, which enable rats access and their spread. Cooking habit attract rats and enable contamination. Household waste management, we should talk about. Heating habit and perception stigmatization. At the interpersonal level, we have homemaker inaccurate perception of safe practices, community leaders' key role in raising awareness, farmers' low perception of risk factor. Then at the community level, we have behavior misconception around Lassa fever, which we also highlight, stigmatization, avoid delaying treatment, denying Lassa fever existence, collective lack of knowledge, general skepticism regarding government. Then at the organizational level, we have stigmatization by or towards healthcare workers, poor sanitary practices, household waste attract and feed rats, lack of scientific knowledge among health workers insufficient training on Lassa fever, wrong diagnosis, and rest. Then at the policy level, we have limited access to clean water, waste management, lack of dedicated and detailed Lassa fever communication, low prevalence of Lassa fever testing. So what are the recommendations? Next. So we provide a short-term recommendation at the community-based education level. It is recommended that we should develop culturally appropriate educational material in local languages and in different formats. Train community health workers, which come in form of environmental health officer, religious leader, and traditional leader. Because earlier in the study, we find out that these people have distrust in government, and this distrust is not caused by Lassa fever intervention. COVID-19 and other political issues contribute. So instead of fighting the distrust, we will rather use the people they trust, train them, empower them to do the community engagement so that distrust will be disconnected. That is the recommendation. Then establish community dialogue platform for addressing this misconception. Implement peer education program. This peer education program will be targeting food vendors and market workers. Why we focus on this peer education program is that because of this distrust, we don't want to be the one that will be appearing, but rather we want the community people that they know to be talking about these things, to be engaging them instead of why we provide technical support and training to those persons. Then we environmental interventions based on providing food storage practices, are being recommended, and then distribution of rodent-proof storage containers. Then healthcare strengthening is training of the healthcare workers, and then establish a clear referral pathway from the community to the facility, so that we ensure that once at the community level a case is identified, we mobilize them to the facility, and the facility, when referred, because some after referral, they will leave, instead of going to the ISCH, they will leave to TBA, and they are missed in the referral process, thereby compounding the issue. This issue needs to be addressed at the community level. Then risk communication and behavior change, targeted risk communication strategy to targeted audience, using a social media campaign to address misconception, and then creating of a rapid response communication protocol for outbreak. Then finally, at the policy level, where multi-sectoral coordination is being recommended. But however, there is already a coordination, multi-sectoral coordination. The only problem is that the one head will come and sit down and hold meeting, but each of the various pillars have not really been empowered to carry out intervention. Sitting down to meet in a meeting does not translate into intervention at the community level. So on this note, next. Our call to action is that there should be a paradigm shift to place man at the center of our disease intervention by focusing on their sociocultural interaction with the environment at the very center, so that we address the issues that are bringing in the cases. Why it is good to empower our health system, providing the vaccine, providing the drugs and rest, we need to reduce the burden on the health facility by ensuring that this disease does not even come out at all, by addressing these practices that have been identified. Please, for the sake of space, pictures that are supposed to be placed are not placed, and some other insights are not placed. So you may go to this Moral link and get all the pictures in Edo State and on other states where the study is being conducted. On this note, I say thank you and appreciate the former Commissioner of Health, Professor Obey Akura, the Director of Public Health, Dr. Stephen Shiojefo, former State PED, Dr. Uwa Kurobo, and then NCDC and Breakthrough Action for bringing and funding this research. Thank you very much.
All right. Thank you very much, Dr. Dinye Hitler from Edo State, the Health Promotion Officer, Risk Communication Focal Person, Edo State. This was quite a lot of information coming out of this study, and I grabbed a lot of things, and I'm sure we colleagues actually also grabbed a lot of things. So looking at the findings ranging from insufficient dedicated scientific knowledge, lack of information, structural barriers, unsafe eating habits, a whole lot of them, and systematic denial, that caught my attention. Systematic denial, even leading to stigmatization and the rest. And this call to action suggesting that man should be at the center of this disease intervention. It's time to start focusing on the people that are affected, find out what they think, their perceptions, and what their challenges are towards behavioral changes. So this is quite a lot of information. Thank you very much. So colleagues, like I said, the Q&A box is there for your questions, and I'm seeing some questions there. So during the Q&A session, it will be addressed. So because of timing, we're going to move to the next item. But before I do that, I want to please check if Dr. Benga is online to introduce the chairperson. If he's not, we should continue. Any feedback? Okay. All right. So we'll continue while we wait for Dr. Benga and the chairperson, which is the DG NCDC, to come on board. So let's go to the next item. So the next item is going to be a section on the role of community listening and collaboration in disease control. This is Bauchi State experience. To do justice to that will be Mr. Sani, who is the infodemic manager, focal person in Bauchi State Primary Health Health Board. So, Mr. Sani, are you online?
Yes, I'm online.
Beautiful. So your slide is up. You have 10 minutes to deliver your text.
Okay, good morning all. All protocol duly observed. I'm going to present the role of community listening and collaboration in disease control.
Sorry, Mr. Sani, can you draw a little bit closer to your mic? Your audio kind of shaking.
Hello, can you hear me? Hello.
Go ahead. We can hear you
now.
Go ahead.
Yes. I'm going to present the role of community listening and collaboration in disease control about your state experience. As mentioned, my name is Sani Hassan, State Infodemic Manager for Bauchi State. Next slide. Going by the introduction, many Nigerians are being affected with Lassa fever. It is a serious concern, especially in the state. I believe I live in the state I live because we are among the top in the list that the state that reporting Lassa fever cases every year. The way Lassa fever spread in the state is very worrisome. And the worst part of the problem, people are relating the illness with belief, which either a witchcraft or an illness coming from the gut. And this belief has become very big barrier in preventing people from health-seeking behaviors, especially in community called Weaba in Bauchi State. Community listening play a vital role when addressing cultural barriers, cultural factors. Next slide. In community listening, especially in Weaba, what we understand the community needs. And by understanding the community needs, we understand the community needs through our community resource groups that enter house to house and sensitize the community and using community informants. This community needs help us to understand the community and addressing misinformation through the use of relevant stakeholders. And we build trust with the community stakeholders. And this gives us opportunity to continue the response activities. Next slide. What we do. We use community listening as a tool for risk communication and community engagement activities to address Lassa fever through community listening. Our partners support the strengthening the capacity of the state team to use data to inform its risk communication and community engagement activities, notably among others. By community listening, we review communication materials, including drama scripts, Lassa fever, signs and symptoms, and prevention posters. We listen actively and passively to rumors, myth and misconception around Lassa fever. By doing that, we have recorded a remarkable success, resulting in communities and local government that were not reporting Lassa fever before, and now they are taking themselves to the hospital for investigation and treatment. Next slide. Next slide, please. Next slide, please. Let me share with you a short story of my experience in relation to community listening, showcasing the power of effective data driving in community engagement, risk communication, and community engagement approach. Being a state epidemic manager, and we used to use available community resource groups for sensitization and listening to the community. Often we have received a rumor about mysterious deaths occurring in Via Ward of Kirti LGA in Bauchi State. We have a report that people are dying. People are dying, and the dying has no cause. It has no cause. So the LGA Risk Communication and Community Engagement Focal Person swiftly notified the state response team, which resulted in the deployment of state RRT. Case investigation was done, which suggested Lassa fever. However, the communities were not agreeing to seek medical care due to cultural belief that whenever sick person cross the river between the community and to stop for medical care, a person will not return alive. Often hearing the rumor, the risk communication team prepare the response planning, commencing with community listening and collaboration. As we listen to the community members, we come to realize that the mysterious illness was Lassa fever, which is endemic in Bauchi State. We engage influential and traditional leaders, WDC members, and health workers in order to combat the harmful rumor. Together with the stakeholders in the community, we share correct messages about Lassa fever. It is sign and symptom, preventive measures and treatment. Then later, 1 month, one man was willing to send his wife with what appeared to be Lassa fever across the river to the treatment center. Days later, his wife returned home alive and recovering from this disease. He also, that particular person, come down with a symptom, went and across that river to the treatment center, and he returned back alive too. Then, as I'm talking to you now, KPLG, we convinced many of the people there and are now receiving care by themselves with the support given by the partners and the state government. So this is the story of Via Town. How do we do it? We conducted a town hall meeting. We sourced the information. We used findings from the community listening. We conducted advocacy to the traditional leader. We do community drama, house-to-house sensitization, speaking with religious places, health dialogue, and compound meeting. This is to curtail the rumor that's in circulation and to call the attention of the community members for seeking care. Next slide. In conclusion, the key to effective health communication lies in cultural sensitivity. When we take the time to understand and respect people's beliefs, we build trust and pave the way for lasting change. Let's make culturally sensitive communication a priority. By working together, we can overcome these challenges and create a healthier future for everyone. Thank you for listening, and over.
Thank you very much, Mr. Sani, for that robust and very interesting presentation. There's a lot of takeaways from there, especially the final slide that talked about cultural sensitivity. And by the way, you were on time with your presentation. So I recall a state conducting a Lassa fever campaign, and a lot of funds were actually placed in it. And compliance to those messages was not 100%. And it was later found out that the campaign was not culturally sensitive. It did not take into recognition the culture of the people, hence the failure of the campaign. So that's a very good one, colleagues. Cultural sensitivity, it's a very, very major consideration when you are responding to Lassa fever. It also lies on what the previous presenter said about putting man at the center of our strategy and listening to the community, finding out what they know, what they want to know, and going ahead to strategize and come up with approaches that will address what they know. It is high time we stop shooting blind, we stop targeting blindly. It is right time for us to have a target and also go with a very effective way of getting our target. Thank you very much. And also another takeaway is strengthening the subnational structure to conduct those listening. So it is not a good practice anymore to be coming from the national level and doing all the surveys and the studies. It is high time we now strengthen both the state, the community, the LGA, or the world level, any structure at the state level, to be able to conduct these pools, conduct these listenings themselves, and it will make it more efficient. Thank you very much once more, Mr. Sani. All right, I am seeing questions on the Q&A box. We are taking notes. These are going to be addressed during the sections. So let's quickly go to the next item. So seeing that time is on our side, we're going to go to the next item on the agenda. The next item on the agenda is a very interesting one, and from a very interesting aspect. It's on a community-centered approach for effective communication. So she's going to talk, Mrs. Mayowa Ede is going to talk more around a community-centered approach for effective communication in Lassa fever. So Mayowa Ede is a program officer, strategic communications from Breakthrough Action Nigeria. Mayowa, please, you have the floor.
Thank you, Michael. Good morning, everyone. Today I'll be sharing how Breakthrough Action has adopted a community-centered approach to effectively communicate about Lassa fever, how we have used data to design, refine, and adapt our programming tailored to the needs and realities of the affected communities. Next slide, please. So just by way of reiteration, all the speakers have said, and I want to reiterate that it is important to understand the human factor if we have to make any progress at all when it comes to disease prevention, detection, response, and even containment. You have to understand who the people are, what their psychological needs are, what their values are, what their beliefs are, what is important to them. Next slide, please. So in Breakthrough Action, but just before I go into what we have done in Breakthrough Action, I would like to define community-centered approach as an approach that involves engaging communities in the design and implementation of public health interventions, and it is underpinned with building trust with these communities and leveraging local knowledge and resources. So basically, what is available at the community level. In Breakthrough Action, we conduct community listening in high-burden locations to understand local perceptions, fears, and knowledge gaps. We synthesize research and studies to assess and capture nuanced insights. We try to co-develop culturally relevant communication materials such as job aids, radio dramas, and even games and digital products that promote priority behaviors for prevention of infectious diseases. We build the capacity of and collaborate with local leaders, women's groups, world development committees, and even volunteers to disseminate messages and model behaviors. And thereby we empower the local champions within these communities, just as the previous speakers have talked about. We also try to establish two-way communication channels, such as town hall meetings, community dialogue platforms, and even WhatsApp groups to disseminate information, collect feedback, and refine our intervention based on the information we receive. Next slide, please. So just a case study and an overview of Lassa fever. If you look at the diagram to your right, it shows the trend of Lassa fever over the last 6 years. And as I'm sure we can all observe, the trend is basically the same. It has not changed over the last 6 years. So you see the peak around the same period, the same epi week, and the drop around the same period. So that means that all the interventions we've been doing, we need to do more. Things have not changed. So we need to begin to rethink our interventions. We need to sit back and see, what are we doing? What can we do better? How can we improve on the programming that we have done? Dr. Hitler alluded to some of the main challenges that we have experienced with Lassa fever. And I would just like to reiterate that we are presently in the Lassa fever season. Lassa fever season typically starts from November, the dry season, and lasts up until April. And he talked about, and I would like to reiterate, the late presentation of cases. The later somebody infected with Lassa fever presents to the facility, the higher the chances of fatality. There's a poor health-seeking behavior among affected populations for various reasons, including stigmatization, including access to facilities, including cost of treatment, in some locations. There's also an ignorance of Lassa fever in high-burden communities such that they are unable to relate the rodents that they see to Lassa fever, or they're not able to relate their poor hygiene practices to Lassa fever. Finally, there's a lot of unsanitary conditions, poor hygiene, environmental, food hygiene, and personal hygiene in a lot of these high-burden communities. And that also contributes to the high spread of Lassa fever, especially along the agric value chain. So I'm talking about farmers, marketers, market vendors, and that agric value chain, especially in high-burden communities. Next slide, please. So looking at this picture, I'm sure a lot of us will recognize the behavior. We try to design programs for people. We try to do what we think is best for them. But the reality of behavior, human behavior, is always different, or it's most times different from what we hope, they do. And we design programs and make assumptions that information is what is necessary and sufficient to change behavior. We also assume that if you build it, they will come. But that, we have seen, is not always the case. And that is why Breakthrough Action tries to think through, how can we use data better? How can we involve people better to make sure that whatever behavior we are preaching is relatable, it resonates with them. It's also from them, because they're telling us what is feasible. It's about self-efficacy. What can I do versus what are you asking me to do? Next slide, please. So since 2022, Breakthrough Action Nigeria has done intentional learning related to Lassa fever, and we've tried to synthesize these learnings and lessons to co-develop and co-design interventions that can shift behavioral and social norms for Lassa fever in Nigeria. We strongly believe that if we can apply these learnings in the 3 states that contribute the highest to the annual incidence, the narrative will change for Nigeria. The burden of Lassa fever is spread between 3 to 5 states mostly. And if interventions are focused heavily on these states, then we can scale up Lassa fever prevention in the country. So Breakthrough Action has learned from existing studies, but also contributed to generating evidence by conducting community listening activities, direct and indirect observation, rapid perception surveys, human-centered design, but also looking at some of the reports that come when people go out to the field. When they come back, what are they saying? What are they seeing? What can we learn from these field activities? And even other research studies within and outside the country on Lassa fever and the findings and insights. Next slide, please. So one of the data approaches, or one of the research approaches we've used, is the human-centered design. And the human-centered design kind of just tries to understand community members' motivations and barriers to the healthy behavior you are preaching, to be able to help them, take on possible attitudes, beliefs, and improve their behaviors generally. So what HCD does in summary is try to increase the empathy and understanding of people's realities and lived experiences and leverage them into system level interventions so that you are able to bridge the gap between intention and action, because people sometimes intend to do right, they intend to do well, they intend to change their behavior, but for several reasons, they are unable to. What HCD does is try to create a bridge between that so that you are able, people are able to take on the action that they know is best to do. HCD involves collaborative research studies before, during, and after the outbreak. And not to go too much into it, we started the HCD study since 2022. And we kind of learned the people we should focus on. One, general population. We need to increase people's knowledge about Lassa fever, signs and symptoms, prevention practices, and the like. But we also need to focus on healthcare workers as a community. They need to know prevention practices. They need to have a high index of suspicion so that when they see a fever case, malaria is not the only thing they're thinking about, or a high fever as referred to by the previous speaker. We also needed to focus on the agric value chain community. So basically that community that takes food from farm to market, right? So you're talking about the market vendors, the road vendors, and the farmers themselves, targeting the key stakeholders along that chain. And at the end of this, we kind of designed solutions. We co-designed with these communities. So they were part of the idea generation, the brainstorming. They were part of the the testing and the adaptation and refinement of all of these solutions, which implies that these solutions are more likely to be accepted and sustained. Next slide, please. So for knowledge, attitude, and perception survey, we kind of learned that effective communication requires continuous listening, adaptation, and feedback. You continuously have to go back to the communities, hear what they are saying, engage with them, conduct dialogues with them, and design interventions based on these conversations. The picture you're seeing up there is a community drama that we conducted in one of the states. It is kind of defined by the community. So community members are part of the drama. They are able to relate to what is happening in the drama. They're able to see themselves, and also model better behaviors, through this program intervention. With our knowledge, attitude, and perception survey, we were able to leverage trusted community structures, existing community structures, which helped us to ensure credibility and also uptake of messages. Next slide, please. So we conducted rapid assessments in high burden states, so Bauchi and Ondo states, and insights from all of these assessments, because we had to see what was going on in most affected communities versus communities that were not affected. So what were the difference in their practices? And these rapid assessments are done usually in an emergency, given the rapidly changing environment. So in the middle of an outbreak season, for instance, and as new information arises or as the emergency progresses, stakeholders will have different needs. And that is what we try to find during these rapid assessments. And when we get this real-time data, it allows us to do targeted and timely adjustments to whatever program interventions we are disseminating or putting out there. Next slide, please. Dr. Hitler talked about a lot of the direct and indirect observations that were done during the HCD, but it's not only during HCD, we try to do facility observation walkthroughs where we engage with healthcare workers within and outside their work environment to see what their operations look like. What is the main issue with a healthcare worker? Why is it hard for them to think of Lassa fever first? Why is it hard for them to pick up infection prevention and control measures, even though they know what to do? And what facility observation walkthroughs help us do is see what is going on in the communities and talk with these people and help us understand their challenges and issues, which helped us to design materials and job aids directly for them that will kind of support the work that they do. Next slide. I just would like to mention, for us, we looked at healthcare workers not just as a community, but also as messengers and an audience. They are affected a lot by Lassa fever, but they are also the channel through which the community gets messages and can get better information on Lassa fever. Next slide, please. So when it comes to localizing communications and engaging the community, the role of the messenger is just as crucial as the message itself. We have learned that utilizing a variety of mediums not only reinforces the message, but also increases exposure of community members and drives meaningful engagement with the behavioral interventions. So by strategically choosing channels such as social media, community events, traditional media, and even local partnerships, we can ensure that our messages resonates deeply with our audience. So we're able to tailor our tone, our style to match the different platforms, which will help improve receptiveness with the audience, ultimately fostering a better informed community. So these are some of the message channels we've used. We've tried to use community volunteers and interpersonal communications. We have discussion guides that can be used by local trusted voices, ward development committees, and even health promotion officers within the community. We have local language posters that are placed in strategic locations, and we have even the digital interventions, the games that help people to learn more about Lassa fever. And of course, we have our radio drama, which uses entertainment to educate people around risky practices and better behavior. Next slide, please. So, BA Nigeria's experience underscores key learnings. First of all, empathy must be applied to understand the lived experiences of community members. You must be able to put yourself in their shoes. You must be able to understand their languages, understand the sociocultural nuances, understand the different sensitivities of these communities. Secondly, it is important to collaborate with community members to improve their buy-in, to improve the ownership. They're taking control of these interventions, and also to increase community resilience. The value of ensuring community output with a continuous feedback loop allows for adapting strategies as needed. And finally, there's a need to build trust by listening, being flexible with your messages and solutions, and integrating these solutions with community needs. So, for instance, if you're going to talk about Lassa fever and the community is telling you, look, we are hungry in this community, you need to be able to find a way to integrate whatever message you're giving them to what their needs are. Because if you do not do that, the community feels like you don't care about us, you only care about what you come here to do. So jointly working with these communities, localizing communication helps to show them that, helps to build trust, and tell them, I'm here for you, I'm listening to you, and I'm working with you, and this can be better. Next slide, please. Now, I'm hoping that we are learning that a community-centered approach is not just about dissemination of messages. It's also about listening. It's about learning. It's about co-creating solutions that are rooted in the local realities. Some of what we have found as a result of our community-centered approach is that we have seen that there's increased engagement with preventive practices, because if people know that you're not just telling me this because it's a propaganda or it's an agenda or it's a mandate that the government has given you, but because you care, it makes your interventions more effective, right? There's also a greater trust in interventions from credible sources. Now, what is credible to one community, or what is trusted in one community, is not necessarily the same as what is trusted in another community. And we need to be able to build trust with the community by using locally available resources and sources. And you have to, be a part of the community to be able to identify that in the first place, right? There's also stronger community ownership. That means that communities can feel more empowered. If you continually reinforce these messages and teach them and help them and build their capacity on how to, adopt all of these healthy practices, eventually it would scale up, because when it comes to public health emergencies, it's not a matter of if, it's a matter of when. The next public health emergency is just around the corner. So what the RCC, Risk Communication and Community Engagement Unit, tries to do is integrate priority health behaviors that can kind of help cover most infectious diseases. So for instance, the life course approach to vaccination, reducing stigmatization, improving personal and environmental hygiene, reporting early to the health facility when you notice you have a fever, ensure you go to a health facility. So when you tell all of these messages, in different ways, then the community can, take charge of their health. Next slide, please. In conclusion, it is important to adopt data-informed, community-driven methods in the work that we do. There's also a need to collaborate and share knowledge to be able to scale up these approaches for greater impacts. I will leave us with the final thoughts. Next slide, please. It is important to remember everybody knows something and nobody knows everything. So by working together, we can improve all our knowledge collectively. Thank you so much.
Thank you very much, Ms. Meiwa from Breakthrough Action. This was a very interesting presentation. Go back to the previous slide. The last what she left with us was everybody knows something and nobody knows everything. Engaging community members as partners, not seeing them as something you can use or a stepping stone to achieving your goal. Make them a partner. My mother was is it your know well? Allow me. So these are the community's problem. It is good to involve them at the beginning, the first stage, down to the last phase. I also like the points about empowering champions. So there are influencers in this community. There are people that can actually be champions to your cause. Reality of human behavior. That was a good one, again, from this presentation. The young generation would say, human behavior, you will fear. People behave differently, and it is very difficult to be able to change them. I recall when I was outside the country, I never had a horn in the country I went to. But immediately I entered Niger, in the traffic light, before the red light would go off, they were honking at the back. And so this is the behavior. It varies around communities. So it is what we are actually trying to change and help the community to be able to avoid, prevent, and control most of the risks involved with Lassa fever. So without wasting much time, thank you very much, Ms. Meiwa. We'll go to the next item. But before we do that, I want to introduce you all to someone very special. His name is Michael Olonite. Sorry if I didn't do justice to that name. Michael Olonite. I don't know if you know him. He's popularly known as Baba Lassa fever. So I want to give him a little bit of time to come tell us about his experience with Lassa fever. And after that, we are going to play a video on the story of Baba Lassa fever. Baba Lassa fever, Michael Olonite, are you online? Okay. If you're online, please, can you speak? We can hear you, or I think we'll continue. I think he's not online.
I think let's play the video, then Elijah will grant him access.
Beautiful. All right. IT, please go ahead with the video. Colleagues, please let's watch, listen, and welcome with questions. Go ahead.
The environment where you are coming from is not the same, but there is one sickness, killer disease sickness, called Lassa fever. So that Lassa fever is rampant in Ondo State. Let me tell you, in the whole Africa, Nigeria is the highest recorded Lassa fever epidemic. Then, when they now check the entire Nigeria, Ondo State have to rate #1. I believe that Lassa wouldn't have much damage in our country, Nigeria, and at our environment here in Ogbese, Ondo State. It means information and the disbelief of our people They always attach many things to spiritual, and the spiritual people use it to consume them. And when it is beyond their power, it might be too late. Some even still die quietly. In fact, due to the temperature of Lassa, somebody might look to be semi-mad. Because I even say to people that I will call Lassa hell on earth. One of the fateful day, I have to visit one of the house of the members in which a granddaughter fell sick seriously. So I assisted. My temperature continued to increase due to the information that the lady is Lassa positive. A team of trackers, they follow up and they refer me to go to FMC. That's how I get to know that I am a patient of Lassa. Our people always argue a lot that maybe it's a lie. If everybody says it's a lie, I am telling you now that it's not a lie. One of our sisters, she was already admitted at the FMC, but suddenly one of her friends called her that it's a spiritual attack. The native doctor have informed her that they should bring her down quickly, otherwise she's going to die. That makes the woman to discharge herself. But at the end, the second day she got there, the thing become more tougher. So that makes her to call me again. And that makes me to assist her to get back to the Lassa department. And today, thank be to God, she's alive. That's how people continue to have belief that there's Lassa. That does not mean somebody will complain on her. Being a survivor, I try to make a lot of advocacy among children, in the marketplaces, in the churches, in the mosque, wherever I can get people to talk to, I talk to them to make sure that I use myself as a physical example. Right today in our house?
No. Yes.
Are you sure?
Yes.
Right Eku, where do they talk?
Lassa fever.
Again?
Lassa fever.
Out of the work of my advocacy, at least over 500,000 people I have talked to one-on-one. Some of them are trying to change their attitude. So which means it's yielding. And I want to believe that it will still yield more. I'll be Baba Lassa. So I will continue to be Baba with the advocate against Lassa.
Yeah, sorry. Thank you very much. This is a very wonderful video. I wish we can give the video a round of applause. Dr. Olayinka, I will hand over to you to continue the section, the Q&A section, and maybe call up Baba Lassa if he wants to come up. Thank you very much, everyone.
Thank you so much, Michael, and great job being done by the three facilitators. There's no doubt they've been able to convince me the need to center communication around people, around the community. We've also heard how survivors could be advocates. We've heard different perspectives related to how do we localize communication. And key things that have come out is the need to understand people's perspective, again, their values, their drive, their motivation, and even the challenges. And people say hunger virus, the economic challenges, and how it's affecting behaviors that people practice. So without further ado, I would go straight into the Q&A box, and I hope all my facilitators, presenters are still on the call to take some of these questions. So one of the questions is, people of many rural communities are switching to wild animals as source of protein, meat. For example, giant pouch rat, because they are so cheap due to the current economic hardship. This attitude can lead to silent spread of emerging zoonotic disease. Is there any measure to be taken about this? Dr. Hitler, are you still on the call? Do you have any response to this question? Okay, Dr. Hitler has dropped off. So I would attend to that, but I wanted the presenters to take their questions first. In view of the LGA financial autonomy, would it be right to advocate with the LGA chairman on the idea of providing industrial food drying machines at strategic places, subsidized raised and powered by solar energy? Sani Hassan, would you be able to respond to that? What are your thoughts on advocating to LGA chairman?
Yes, we are on that track. We even past that level because we have already conducted advocacy at the chairman, and we are trying to meet the state legislation for electing law that maybe they will assign some allocation for that potentially Lassa fever issue, because the Lassa fever issue is becoming very worrisome. Okay, we are always leading in terms of Lassa fever cases. Okay. So we asked our health promotion officers at various levels to advocate LGA, and they have conducted it. All the LGAs have conducted advocacy. The leadership of the Algon, then the state legislation also have conducted one advocacy, and we are planning to also. Thank you.
Thank you, Sani. Basically what he was trying to respond is, yes, to Chibuzo's, again, suggestion. We know that there is financial autonomy now with the LGAs, and definitely the issue related to food security, food safety is an important one. We need to look at how we do alternative measures to food drying, food processing, and being able to have this taken at a strategic approach. So as part of, again, we're entering another Lassa fever season, and the onus is on every one of us. You're an advocate at any level to be able to reach out to those who can be able to support things around, again, industrial food processing machines, and then at subsidized rates, and of course, addressing our economic light power issue, making sure that it's connected to solar energy. So great submission or recommendation by Chibuzo Eze. We have another question that has to do with some of the things the panelists have already talked through, high index of suspicion amongst clinicians. So most of our clinicians do not really hold a high index of suspicion for Lassa fever. This is the reason why the fatality associated to this case is usually high. We also need the clinicians to also make a report to the State Public Health Department about signs, symptoms, and trends of any confirmed Lassa fever case, so that a careful study and comparison can help us easily identify Lassa fever at earlier stages without taking much time waiting to treat malaria and typhoid before suspecting Lassa fever. Saliu Dubé is again touching on key points around high index of suspicion among Lassa fever. And I believe that was one of the recommendations from both Dr. Hitler and Meiwa on the need to make sure that healthcare workers across board have improved knowledge on Lassa fever. So where we see issues is the fact that there is a high concentration on capacity building at treatment centers, and then the PHCs, where it's likely the first point of call for most cases, do not have enough high index of suspicion. Even our private health facilities, to what extent can we think through, again, making sure that healthcare workers are aware. And so this is the time now. So again, for every health association, in terms of professional association, from doctors, nurses, laboratory workers, everybody within the spectrum, pharmacists, how we engaging them at this point in time to start looking outside malaria, typhoid fever, for any case of fever. How do we provide them with practical job aids that helps them to, again, rule out, if it's not malaria, can I test for XYZ? So those are kind of recommendations going forward. There's a question around, are there natural bodies or elemental forces that make Lassa fever more endemic in some states than others? What are the warning signals that suggest a possibility of Lassa fever in a community before it happens so it can be curbed headlong? This is related to early warning. And I would say it's perhaps when the surveillance pillar is making their presentation, they can provide more evidence that supports what is happening across states. If there are commonalities they've seen across some of these states. So this will be moved forward to the TWG or the surveillance pillar presentation. Please take note, Olukoya Ogumbanwu, that will be shared with them. Yaya Mohammed did put on, an addition to what the Bauchi experience is, we use Lassa fever survivors sharing their testimony and how they were treated at the Lassa Fever Isolation Center in ATBUTH Bauchi. That motivated others to report to their relatives, others to report to their relatives to the authorities. I recall when Dr. Hitler was making his presentation, and he did emphasize the fact that people viewed the treatment centers as a place of no return. And Yaya Mohammed's contribution is their experience in Bauchi, where they did a video around the treatment center and experience sharing by survivors on their own Lassa fever experience, how they entered the treatment center and how they are going back home. And this has helped to motivate others again. So we see that families really do not want to report their loved ones when they see them having some illnesses, but his update is that they've seen how relatives are responding to notifying the authorities of this. This has motivated a change in behavior. Oliver Anozie says, we've heard over and over again how stigmatization has and is affecting the way people in the community seek help, especially with Lassa fever infection. What is being done to reduce stigmatization and instill more confidence in people to seek professional healthcare help? Meiwa, would you want to respond to that? How do we address stigmatization, or how do we reduce stigmatization?
Okay, no problem. I can attempt to respond to that. Thank you so much, Oliver. You're absolutely right. Stigmatization is one of the reasons why a lot of people, even among healthcare workers and their peers, why a lot of them do not want to notify if they see or feel, Lassa fever symptoms. But what we've tried to do is improve knowledge around the disease, because Lassa fever is just like any disease. The difference is in how it presents, right? So if you don't stigmatize somebody for having a cold, for instance, and if you don't stigmatize somebody for having malaria, why would you want to stigmatize somebody for having Lassa fever? The main reason is a lack of understanding. You do not know, you do not understand how to protect yourself, how to protect the person. You do not understand the precautionary measures, you can take, to keep everyone safe. So what we try to do is address those gaps, those knowledge gaps, that lack of understanding, preach the message of infectious diseases can happen to anybody. So you just need to be careful. You need to be mindful and support your loved ones and your community by notifying not authorities. I don't like to use the word report and notification because it's not like you are reporting somebody for doing something bad, but you just care enough to make sure that this person seeks help and gets better. So I guess that's what we try to talk about with the communities, help them understand better what to do, how to protect themselves and their loved ones. Over.
Okay, thank you, Maywa. There were some questions that entered the chat box instead. There's one related to transportation, samples. So that will also be moved forward to the TWG and the laboratory pillar to respond to. I also saw one, so test tube be given to health centers again. So that's taken note of, and it will be given to the laboratory pillar and TWG to respond to it. I don't think we do have, is Dr. Hitler back? There is a specific question for him. Unfortunately, he's not here. He said, you mentioned that an interviewee mentioned increase in rat population after introducing rat bait. It seems logical that more rats will visit locations where they can get food. Is this scientifically proven? What could be the impact of such attraction? I'm not able to respond to this. It was directed at Dr. Hitler, but unfortunately, he's not on the call. There's also an input from Henry Ochulo, saying rather than always emphasizing on number of cases during outbreak, it would be of more benefit if consent is sought from the relatives of affected persons to display and showcase publicly those who are down with Lassa fever. This will make more impact and help others take precautionary measures. So again, consent is what I'm reading through here. I'm not sure if this would exacerbate or address stigma, because what's being shown is what Henry is trying to communicate is that engaging with survivors, that's what I'm taking this as. And we've demonstrated some of that with people like Babalasa. So Elijah, if we can add Babalasa so that he could also just share again one or two things, and then we can move forward. I am not sure there is any more questions for us to respond to.
Okay, may I know what name did he join in as?
Use the Michael Olonote. There are two, but yeah, the correct one will unmute. So apologies for the break in transmission. Yeah, we're trying to connect you, Mr. Olonote. Okay, you can go ahead and unmute.
All right. Good day to the whole house. Can you hear me?
Yes, we can hear you.
All right. All right. I am Olonite Michael, generally called Baba Lassa. I am given that title by the people due to my attitude of trying to enlighten people. And then all I know is that the video you saw is a reality. I've narrated a lot over there. All I determined to do is to use my own personality and as a survivor to make sure that other people don't fall victim. And with that, I try to do the campaign even on my own. But if every other survivor can try to come all out, remove shame, there's nothing like a stigmatization. If you stigmatize me, I will not be ashamed. Later, you will come back to join me. So if every survivor can be enlightened to do that, it will be of a good thing. And like some of the questions I sent down, if the government can equally invest more on the publicity. In fact, we need to go to the nooks and crannies of villages. And due to the economy, individual cannot do that. Breakthrough Action has tried a lot to train us as well, because I'm one of the champions for change in those states. So we are trying our best. So I thank you for inviting me into this forum, and I promise to do more internationally. May the Lord bless the whole house. Thank you. I think I have to stop here, except if there's a question.
Thank you so much, Mr. Olonite, for again blessing us with your experience and your voice this morning. And we appreciate the personal drive and advocacy you're taking to make sure that people are aware of Lassa fever. Again, like Maywa said, it's just like you have malaria too. So again, you have headache. Lassa fever is a disease. Why do we need to stigmatize? And really saying we need to push the message to every nook and corner and really work with survivors is really great to know. Thank you so much for all you do for your community and to the world at large. Thank you so much. Before I hand over back to Michael, so with regards to the issue related to animal source of protein, so my take is do no harm or harm reduction. And so when it comes to harm reduction, how can you practice that in what you are eating? So food safety matters, food security matters, food safety in the sense of what are you consuming, even if it's the chicken, even if it is the cow, even if it is the goat. Key things you need to do what is what? Wash well, cook well. Any food before consumption. So it's all about safety. It's all about harm reduction. It's all about understanding that there are multiple elements to what people would say, do. It's really not about the only information you put out there, but there are multiple contexts to actions people take. I hope you understand me. So there are multiple. If I can't afford it, yes, so do away with protein or do with what is available. If it is do with what is available, how can I make sure it is safe for consumption? I hope I've been able to kind of like give you an idea of how do we look at the economic realities to the sociocultural context to behaviors that people need to practice to stay alive and well. Back to you, Michael.
Yeah. Yes, just like you said, ma, all these ideas, we discover that poverty sometimes does not make people to feed on what they're supposed to. But I think even the villagers too, the Lord bless them with some grain and fruit. So we do encourage them to make sure that they feed well. They feed on what they can lay their hand upon and try to be hygienic in nature. So if they do all this one, washing of hands, and they're using sanitizer, if they can lay hand upon them, all this will still reduce the communication of these diseases. So come to my own environment, all I know is that I don't even have a limit to my talking. So anywhere, last week I was in Ede. So I gave a presentation there in an international forum. So I believe that God, by his own infinite grace, he will help us to eliminate Lassa from our vicinity. So let people feed well and drink water and try to report early. So I, as a person, I'm ready to volunteer myself to any part of the whole world to make sure that people understand and they do the needful. Thank you.
Thank you so much, sir. Again, for capping it all up. There are other sources of food available that people can look into. Thank you so much, and we appreciate your advocacy. So it's back to the moderator.
Okay. Thank you, ma'am.
All right. Thank you very much, Babalata. Thank you very much, Micah. Those are very information. And hopefully you are going to be the ambassador and the champion for not just Lassa fever, but for other disease outbreak in your community. Thank you for the good work.
Thank you, sir.
All right. So to move ahead, I think we are in the last session. Before I go ahead, I want to see if Dr. Benga made it to the webinar for him to introduce the chairperson. Is this Dr. Benga, are you online? Okay. So I guess due to a lot of conflicting activities, they were not able to make it. But in subsequent series, I'm sure they can make it. So the questions, most of them have been addressed. Those that have not been addressed, there are other series of webinars coming on. So, and I assure you that they will be handled and also addressed in those series. So, like I said, there are going to be other webinars on surveillance, case management, IPC, and a whole lot of it. So this is a continuous process. So I will hand over to Mrs. Hanatu Bello to help us with the conclusion and wrap up and summary of key takeaways from this section. Ms. Hanatu Bello, are you online?
Yes, Michael, thank you very much. So first of all, good morning once again. I would like to commend the presenters, even the moderator, the question and answer series. I think this has been wonderful. It's been very interesting. For me, localizing communication driven by data, guided by social cultural events around us, with making data as a key entry point, you know, for us to look at the people-centered approach, community-centered approach, through the human-centered design, trying to understand the people, working with the people to even design the method of approach or intervention, taking into consideration the user perspective of such interventions, of such materials that will be developed. You find out that a number of words are standing out to me here. I'm thinking empathy, very key, building trust, understanding the feelings of the people, putting ourselves in their shoes and feeling the pulse, feeling the pains where they feel it. And then, of course, in all of this, the need for us to include the health workers, bringing on board One Health players, and then trying to understand the need for the socio-culturally sensitive messaging, using trusted local voices, the need to understand the people, the need for continuous refinement of whatever messages we are putting out there, design, working with the people from beginning to the end. All of these put together will definitely pave the way forward for us to have certain impact, such as increased engagement of the people. You know, we get to find more people becoming more aware of the situation and what we are dealing with. You know, we are able, greater trust is built, and then because we are using, because of the use of trusted sources, and then of course, the issue of community ownership comes on board, with the people trusting those who are helping, engaging with them and helping them to have an intervention to address the situation at hand. They try to own the situation, and it becomes their responsibility as well. And this brings me to collective responsibility. I like saying that everybody needs to play a role in this address. One of the presenters talked about everyone knowing something and no one knowing everything. If we all collectively bring what we know on board, work together as a team, I am sure that we will achieve success by the end of the day. And of course, this brings me to strengthening collaboration between not just the community members and the people engaging them, the HPOs, the RCCE members that are engaging with these community members, but of course, also strengthening collaboration between the surveillance arm of this response and the health promotion officers, which also came out at the recently concluded ADSRM meeting. There's need for strengthened collaboration between everybody who is a stakeholder, everybody who has a say in the business of responding to disease outbreak, in this case, especially Lassa fever, in order to work together, understanding the fact that we are now localizing our communication. We know where the head of the needle is, and we know the point at which we want to stick it. So thank you very much, everybody, for having been here.
Sorry, Ajia, before you conclude those apologies, I think we have a little bit of time to accommodate the two hands that are up. So if I may plead with you to just please hold on a little bit before you conclude the meeting. Let's
All right, no problem. I am waiting. I'm waiting. No problem.
Beautiful. All right, colleagues, let's hear what two of our colleagues have to say. I'll start with Audu Kwoko. I don't know, is it possible, IT, to get them to speak? Hello, IT, is it possible to get them to speak? Okay, beautiful. Audu Kwoko, you are you have a mic. Please unmute your mic and go ahead. Audu Kwoko. All right, let's go to Eugene Samuel. Eugene Samuel, you have the floor quickly. Oh.
Hello, I please, sorry.
Audu, go ahead, please.
Oh, okay. Sorry, I just want to first of all appreciate the insightful presentation on the studies made on the issues around the Lassa fever, the level of combatant. But one thing that I want to inquire most especially in Nasarawa State, we have a number of cases of Lassa from previous years, and we are into the period now that some of those issues of Lassa. So as a health promoter, I'm looking at other avenue that our community will be sensitized on how to prevent themselves the food preservation, because we are getting into the dry season, and this is the time that the agents carried out their infectious activities to humanity. I'm seeking for the support, especially from the NCDC, just as you have been doing previously. If you can still raise that banner to support the state in the aspect of risk communication activity, especially to the community level, so that we can re-equip ourselves with the needed information and the possible approach that we can do, as well as the healthcare workers, because they are also the first contact of individuals that will meet with clients or patients of this Lassa. I can recall the previous loss of vibrant doctors in the state, and this is a concern, and I'm looking at if NCDC and other organizations that is on this call.
Okay. Chief Audu,
to aid of the state, that we can be able to mitigate this spread of Lassa, even as we are reaching the epic. Thank you.
Beautiful. Thank you very much, Chief Audu. Thank you for this input. So I can assure you of something, that the approach towards response to Lassa fever is a coordinated approach. We collaborate with NCDC collaborates with partners, stakeholders, both community and state, and at the national level, to make our approach more efficient. So I'm sure we'll keep up this coordination to make sure that we bring to the states the capacity to strengthen most of their strategies, if not all of their strategies. So you are rest assured that collaboration will always keep existing. And we thank you for actually appreciating the partners and other stakeholders that support this fight. So I think that will be all. If there's no other hand, Adja, I think I will hand over to you one last time to just close us for today. Thank you. And colleagues, please, there's a link for attendance in the chat box. Please ensure that you fill in your details and to be able to get more announcements for more series of this Lassa fever webinars. Thank you. Adja, you have the floor.
Okay, so thank you everyone for your time. First and foremost, for your commitment to stay true to the end, and for the planning committee for doing a very good job and ensuring that this outing is a success. We look forward to being part of future webinars coming up, inshallah. But then at the same time, I want to leave us with these parting words. I would like to encourage all of us in the spirit of collective responsibility to address the issue of Lassa fever prevention and control in our communities, to imbibe the actions of Baba Lassa. Let us see ourselves as advocates. Wherever we find ourselves, please, even if it is just a word or two, let's chip in something. Who knows, you might just be saving a life. With these points, with these words, I'd like to say, enjoy the rest of your week. Thank you for attending this webinar. I wish you all the best. Goodbye.
Thank you very much, Ajia. Colleagues, thank you very much for attending. And I think this is the end of the webinar. And thank you very much, everyone, and goodbye.